According to the Global Initiative for Chronic Obstructive Lung Disease, GOLD, 2019 strategy document, COPD is a common, preventable, and treatable disease characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. Approximately 16 million Americans have been diagnosed with COPD, with another 12 million estimated to be underdiagnosed with COPD. COPD is a leading cause of disability among Americans and the fourth leading cause of death, following heart disease, cancer, and drug overdose. 70% of persons with COPD are in the workforce, and both related absenteeism and presenteeism place burdens on employers. The economic burden of COPD-related patient care in the United States, including direct and indirect costs, exceeds $50 billion a year. COPD is a heterogeneous disease, and it would be a mistake to view and treat all patients with a COPD diagnosis alike. Different types of COPD include those with frequent exacerbations, those with eosinophilic exacerbations, those with upper lobe emphysema, with chronic bronchitis, with alpha-1 antitrypsin deficiency. There are issues with early versus mild COPD, with rapid progressors, and COPD and overlap syndromes, COPD and asthma, COPD and congestive heart failure, COPD and pulmonary fibrosis, COPD and bronchiectasis. Common COPD respiratory symptoms include dyspnea, cough, and/or sputum production. The airflow limitation associated with COPD is caused by a mixture of small airway disease and parenchymal destruction, as is seen in emphysema. The relative contributions of these vary from person to person. Clinical manifestations of airflow limitations in COPD include symptoms, exacerbations, and associated comorbidities. It is important for primary care providers to think about a COPD diagnosis in patients with dyspnea and recurrent respiratory events, including in non-smokers, since 25% of patients or more with COPD in this country never smoked at all. According to GOLD, the following are key indicators for considering a diagnosis of COPD. Dyspnea that is progressive over time, characteristically worse with exercise, and persistent. Chronic cough that may be intermittent and may be unproductive, recurrent wheezing, any pattern of chronic sputum production, recurrent lower respiratory tract infections, history of risk factors, genetic factors, exposure to tobacco smoke, smoke from home cooking and biomass fuel exposure, occupational dust, vapors, fumes, gases, and other chemicals, and a family history of COPD. And childhood factors, recurrent infections in childhood. All of these things apparently increase risk. The Preventative Services Task Force has recommended that if there are risk factors and symptoms, that spirometry be performed to establish a diagnosis. A post-bronchodilator FEV1 over FVC ratio less than 0.70 confirms the presence of persistent airflow limitation and is consistent with COPD. A number of investigators have been working for years now on validating a new approach called CAPTURE, which includes a short questionnaire and peak flow testing to decide who ultimately should have spirometry done. This may well be the test we use going forward. COPD is a treatable disease, and the urgency of early diagnosis and intervention cannot be overstated. In 2012, Tantuki et al. Showed that untreated, faster progression of functional impairment in patients with COPD tends to occur early, particularly in GOLD stages 2, FEV1 between 50 and 79% are predicted, compared with stage 4, where the FEV1 is less than 30% are predicted. While a cure is not currently available, we certainly have medical therapies and non-pharmacologic strategies like influenza vaccine, pneumococcal vaccine, pulmonary rehabilitation, exercise programs that can make a difference, that can improve the quality of lives, improve lung function, and can improve the level of function for persons with COPD. For busy clinicians, the COPD Foundation has developed a tool that encompasses recommendations for the management of COPD. The COPD Pocket Consultant Guide is available for free as an app on cell phones, either through the App Store or Google Play. A flowchart is included for individualizing COPD treatment according to the impact of symptoms, the level of dyspnea, the frequency of exacerbations, and response to medications. This app includes the COPD Assessment Test, the CAT, and a Modified Medical Research Council scale, MMRC, both of which calculate scores. There is a section on medications with a listing of options within a given class, viewed by both generic and trade names, and inhaler education videos for inhaler therapies approved for the treatment of COPD. An updated version of the app, launching just this month, includes a patient track that can serve as a tremendous resource helping patients to be well informed and actively involved in their COPD management. This is, after all, a treatable disease.